warm welcome on this cold Florida day. Okay. Well, we want to welcome you to our symposium. This is the Fall 2023 Student Science Symposium because it's student-led, student-driven, and it's a student showcase. So thank you so much for being here. Before we officially begin our day, I do want to take a moment to recognize all the faculty who are here with us today. So would all the faculty who are here with us or research advisors who are here with us please stand for a moment? Could we welcome them this morning? So thank you so much. So you're going to witness a lot of the student work, student research that's been done this past semester. And so without further ado, I'm just going to give you a quick overview of the symposium. So we have the research residency presentations right now following my greeting. And then at 9:40, we're all going to head over upstairs to the second floor to see the research students and their work. That's all going to be showcased through poster presentations. And then following the research presentations, we are going to have our very first capstone session. So the capstone sessions are going to be in 2 rooms simultaneously. So it's going to be this room and the one adjacent to this, so on the other side of this wall. So once you're done with posters, please head over downstairs. And then we're going to take a lunch break from 12, I believe, or 11, 11. And then we'll return at 12 for our final round of capstone research presentations. I want to thank Tammy Butler for being here as well to witness all this amazing work that you are about to witness. And last but not the least, I wanted to welcome you on behalf of the College of Natural Sciences and the Department of Natural Sciences. We also have 2 of our biology alumni, well, actually more than 2, but 2 of our alumni are here today because they brought their students from their schools here to the symposium. So Michael Gorman, would you please stand up? So we want to welcome Michael. We also have Zach Tony. I don't see him here yet, and his school. But we have Eric Eversole. Eric, where are you? And then Jessica. Where's Jessica? Yes. So thank you all, alumni, for being here as well. So without further ado, I'm going to turn it over to Dr. McConkey, who is going to introduce this first session.
Good morning, everybody. Can you hear me in the back? I feel like this isn't working. It's just for that. Okay, that makes sense. So do I need to hold it? Okay. So first, I would like to present our research residency students. They're going to present first for us this morning. So first up is Ashley Graham, and Ashley is graduating with a degree in biochemistry with a concentration in research and a minor in neuroscience. Pretty impressive. She is from Auburndale, Florida, and has been at SEU for 2 years. During her time at SEU, she's been a part of the SEU Honors Program Leadership for ACS and SCNDA, PHSO, served as Vice President of Alpha Chi, a TA and ACE tutor, a health services student volunteer, and did chemistry research. After graduating, Ashley plans to go to medical school, specifically in psychiatry or primary care. So welcome, Ashley. Do you want to put this on?
Just not, the screen's not turning on.
Go blank. Oh, the video is blank. There you go. Ready? Give it a moment.
Perfect. Perfect.
Oh,
Is it already? Okay.
yeah, go ahead.
Okay. Good morning, everybody. Like she said, my name's Ashley. I graduate next semester, and this semester I had the opportunity to go to Lakeland Regional as part of their research residency program, and this was some of the work that I had started researching while I was there. So the project that I proposed was assessing isolative symptoms in adults of varying socioeconomic status and the effectiveness of eye movement desensitization therapy. So before I begin, I'm just going to kind of go over some ideas that this project covers a lot. And one of that is the idea of trauma and kind of defining it. So trauma kind of triggers an emotional response. According to the World Health Organization, about 50% of people have experienced at least one traumatic event in their life. And how people develop the symptoms of longer lasting traumatic mental illnesses may differ depending on their environment, which was kind of the foundation of why I wanted to look into this a little bit further. Another idea that I'm going to just define real quick is that of socioeconomic status. There are a few kind of, what's the word? So nationally, there's these 3 scales that are most commonly used to define socioeconomic status. And so there's kind of a limit. I'm not 100% sure on the specific limit. But if you're below such status, then it will be, you're considered low socioeconomic status, and anything above that, you're considered non-inferior socioeconomic status. And this status is determined by your household income, your occupation, your family size, your education level, things such as that. And I also want to touch on self-isolative symptoms. These are symptoms that can cause individuals to not be able to be as active in society. They aren't able to hold maybe a stable job. They aren't able to go out and have a better quality of life. And so these isolative tendencies can show to have other comorbid conditions also develop later down the line, such as cardiovascular issues, other mental illnesses, or GI issues. Little overview. So this study is going to be a prospective cohort study, and the groups are going to be differentiated based on those environmental factors. Then for the actual outcomes, I'm going to be looking at the eye movement desensitization therapy, and that is a specific cognitive behavioral therapy. You're basically tricking your brain while you're talking through an experience to rewire the brain in a way on how you think about that experience. And then again, with the prospective cohort study, I'll be using the same therapy for both of them, and they'll be assessed using the DSM-5 CAPS-5 questionnaire. So my specific aim 1 is going to be to identify the limitations of socioeconomic status on cognitive behavioral therapy effectiveness. Basically, does differing socioeconomic status groups have different, what's the word? Is the therapy less effective if you have a low socioeconomic status? And then also through the DSM-5 CAPS-5, I'm going to be able to quantitatively and qualitatively collect information on the effectiveness. So for my inclusion criteria for this study will be patients at Lakeland Regional Health treated for PTSD, acute stress disorder, and general anxiety or depressive disorders. And they would need transportation for outpatient care, as well as be between the ages of 25 to 55 years old. And they would need to be able to read and write in English. And then for exclusion would be anybody with a substance use disorder or terminal illness diagnosis within 6 months prior to the study. And then again, the groups there'll be 200 participants in total. Each group will have 100. One group will be screened and considered low socioeconomic status, and the other group will be considered low socioeconomic status. And there will be a 3-month experimental period, and at the end of each month, the DSM-5 will be reassessed. So since I'm focusing on isolative symptoms, I chose 10 specific questions that are for isolative symptoms rather than just doing the whole thing, because these patients at this point will already be diagnosed with some kind of mental illness. And then they'll be randomly grouped, and then at the very end, statistical analyses will be performed to determine if sex or age kind of differentiates the effectiveness of the therapies as well. And then, so just a quick timeline, identifying the patients, they will be approached at discharge, and they'll be discharging from behavioral health unit or psychiatric inpatient stay. They will, for the assessment, I'm just going to see if they're above or below socioeconomic status, just with a few simple questions from those previously mentioned questionnaires to determine that. And then they'll be administered a baseline DSM-5 questionnaire, and then you'll get your starting point value for their questionnaire. For the experimental period, it'll be 3 months, 2 groups with 100 each. One group will be low socioeconomic status, the other will not. And they will both be given the same eye movement desensitization therapy. And then for collection and analysis, a longitudinal data analysis will be performed to see over time how the isolative symptoms either increase or hopefully decrease. So outcome measurements, again, will be the questionnaire, the DSM-5 questionnaire. This questionnaire, it's the CAPS-5, DSM-5, and it is just the clinically administered PTSD scale. And the longitudinal data comparison, and then by comparing both over time and between groups, we'll be able to tell if there is a variation between if socioeconomic status does have an impact. Anticipated results, a reduction in isolative symptoms on the DSM-5 across the board, hopefully, maybe necessarily less so in the low socioeconomic status group. And hopefully better understand the impact of socioeconomic status on mental health, and also get qualitative feedback as well on the CAPS-5, because there is a 1 through 10 rating of, okay, I felt like this symptom improved. There's also a write-in where patients at different points can be like, oh, this affected how I was feeling at this point in time versus another point in time. And then implications. This was a big part of my study, because this kind of prospective cohort study was just to see if there is a difference. Because if there's not a difference between socioeconomic status, whether it be high or low, then there was really no point in trying to propose a different factor to implement into the therapies. So I would like to focus primarily on low socioeconomic status and use different behavioral therapies to see if one is works better than the other, as well as try to propose for a random control trial a accessibility factor that makes these therapies more accessible to these populations, and to statistically analyze if there is a difference between sex or age in the actual outcome and effectiveness of the therapies. And then my references and questions.
I have a question. Yes. Can you explain to us what exactly they do in with the eye movement? What is the testing like? What is the
Yes. So from what I understood, it's like you're talking through an experience like in a typical sit-down setting, and you're kind of doing things. You're stimulating motor movement to kind of
move.
yes, and you're kind of they have all kinds of different techniques they use, but you're kind of just from what I understand, just distracting. Yes, and
And is it proven already in non-socioeconomic?
So in non-socioeconomic groups. Yeah, so across the board, there's a lot of studies on eye desensitization, therapies and stuff. So I was trying to choose one that is already commonly used and is out there. Yeah.
Is it already commonly used, and now you're studying it in?
Yes.
Just 2 questions. Since this is kind of assessing the symptoms of the patients, and related to the socioeconomic status, do you or have you considered trying to get a evaluation of the patient's mental health status before subjecting to this, in as much as this might have some implications on the condition prior?
Yeah, I think one of the biggest indications would be that initial DSM-5 questionnaire test, just to see where they're at baseline, and then depending on severity, if extra help is needed, clinician help is needed, then it might be subject remove them from the statistic, or just remove them from the trial together. But this is more sort of just observing them, walking beside them, not necessarily.
Right, but I think it's important because you have to have a baseline of the mental status of the patient prior to, because if they already are suffering that has nothing to do with socioeconomic, right? And that becomes now a consideration without really looking into that particular aspect of the patient. I think it's important.
Substance abuse, right? So was there another group you were planning to exclude, or what is the DSM actually?
Yeah, I think that's
The
the problem, is the DSM
yeah.
questionnaire, what is it?
So it's looking at, there's a list of a bunch of different symptoms. It's just a statistical measurement of like mental illness, like symptoms. Yes, that's what it's covering. So if it was, usually all of the 30 questions are used to give a diagnosis of PTSD or whatever different categories you score
But that's
different on.
they're already considered as patients.
Yes.
That's what I'm trying to say. It's like before you even consider patient to be subjected to the analysis of the program, I think there has to be some sort of a free, evaluation kind of.
Yeah, they are. Yeah. They are already pre-evaluated.
Oh, they are.
Yeah, that's what the DSM-5 is for. And they're already diagnosed with these things, with either PTSD, the anxiety, or depressive disorders. So, and then we'd be working alongside the physicians because we're approaching them at discharge before they even leave, just to make sure we're not trying to do something that's more harmful than helpful.
I agree with Dr. Borton. I think there's too many variables here. I think that you have to look at initiation of treatment with your neuroplasticity. So that this is somebody who has an ACEs score of 4 or has a high trauma, and you're initiating EMDR at age 40. What is their response? You can't say they're a non-responder. It's just that they don't have the neuroplasticity if you would have initiated treatment 20 years ago. So I think you have a lot of variables to kind of tease out of here. Also, are they on pharmacokinetics? Are they taking meds? What is their brain? Have they reached max therapeutic capacity with medication? Are they a non-responder to medication? Lots of variables. Happy to help you.
Thank you. All right, so our next presenter is Ashlyn Veheo. She is graduating with a degree in biology with a concentration in medical sciences. She's from Dallas, Texas, and has been at SEU for 2.5 years. While at SEU, she has made the Dean's List, has been a TA for physics, a team lead for production for the Department of Spiritual Formation, a business data management intern, and participated in the Lakeland Regional Research Residency Program. Upon graduation, she plans to pursue her master's in medical science or continue in research and go to medical school in Texas. So, welcome, Ashlyn.
Oh, let me, oh, I. Yeah. You would to move forward, just the and back.
Good morning, everyone. My name is Ashlyn, and I will be discussing the potential effects of 17-beta estradiol hormone therapy, right, on Crohn's disease. So the objective will be, can 17-beta estradiol keep women with active Crohn's disease in remission long enough to get them pregnant? So Crohn's disease is an autoimmune disease, and women who are between the ages of 20 and 30 are typically affected by this. This is because of menstrual cycle and hormone changes. They can experience frequent relapsing, and it is a chronic non-specific inflammatory bowel syndrome that affects your GI tract from the mouth to the anus. This can include lesions, thickening of the wall, ulcers. This can cause diarrhea, weight loss, lack of absorbance of nutrients. in the small intestines, and women with Crohn's disease may also experience psychological disorders such as anxiety and depression. And this can negatively impact your fertility. So inflammation poses as a negative effect to the pelvic cavity. It can lead to further gynecological pathologies such as pelvic inflammation disease. And it can also affect the fallopian tubes and ovaries, as well as cause ovarian damage, excessive pain, and sexual dysfunction. And women may refuse to get pregnant due to hereditary risk. And as you can see here, there's a comparison between Crohn's disease patients and patients without Crohn's disease, and they have depleted values in their AMH, their right and left ovarian volume, and their right and left ovarian AFC values. So the ovarian reserve is the most accurate form of woman fertility. It includes hormone measurements for follicle-stimulating hormone, estradiol, and anti-Müllerian hormone. This also includes age. It is the quality and number of follicles in the ovary to produce oocytes, and it is measured via anti-Müllerian hormone. And the pathology for Crohn's disease is not entirely understood, but what can be understood is that estrogen plays a protective role in intestinal inflammation. It regulates intracellular signaling and activates transcription of estrogen receptors. G protein coupled estrogen is overexpressed at the mRNA level, and when membrane bound, it mediates anti-inflammatory action. So, how it is understood is that the activation of GPER leads to rapid modulation of several proteins that mediates immune response. This increases the levels of protein inflammatory cytokines and affects endothelium and vascular tissues in the GI tract. It can further be explained that there is two estrogen receptors, estrogen receptor A and estrogen receptor B, and they are responsible for many processes in the GI tract. There is a lower expression of estrogen receptor B in active disease form and a higher expression of interleukin 6, a pro-inflammatory cytokine. And the lower expression of estrogen receptor B increases estrogen receptor A. And it is believed that a homeostasis of the estrogen receptors can significantly decrease inflammation. So as you can see here, in a Crohn's disease patient who is experiencing an exacerbation has depleted values of estrogen receptor B versus a normal patient without Crohn's disease. And the relative estrogen receptor A is significantly overexpressed compared to the control. So my study would include women who have been diagnosed with Crohn's disease and report symptoms, and they are between the ages of 18 to 30. This is childbearing, and they're able to give consent. They have been trying to conceive for up to 1 year, but are unable, and who are also experiencing exacerbations regularly. This will exclude women who have had bowel resections, a Leo pouch, and reproductive surgery, as well as using contraceptives, smoking, and history with drug and alcohol abuse. My specific aim 1 will be to measure the effect on inflammation, then to measure the effect on the ovarian reserve, as well as the experimental will include 50 women who will be receiving the treatment and 50 women who will receive no treatment. We'll be measuring their Crohn's disease via the Crohn's Disease Activity Index, and we'll measure their ovarian reserve every 3 months between days 2 and 5 of their cycle. So for the experimental, the woman will be administered 1 milligram daily, and at 1 month, their creatine and electrolyte levels will be checked, and if there are no concerns, then 2 milligrams daily, and at 3 months, levels will be checked again. The control will again receive no treatment. The measurements will include the Crohn's disease activity index and the ovarian reserve testing, which is transvaginal ultrasound and blood testing. And the expected results will be a downregulation of estrogen receptor A, an increase in estrogen receptor B, decrease in inflammation and symptom severity, as well as an increase in thickening of the uterus lining. And further methods will include recruitment through physician referrals. The statistician will be blind. This will be a factorial design, which is a comparative design. Patients will be informed of health risks and consent will be necessary, and the Declaration of Helsinki will be followed. And this way. Yes.
Questions for Ashlyn? What do you
So this hormone in particular has been proven effective in males. There's been a study that has been recently been done where this has regulated the estrogen inflammation in males, but it has not been proved, like it hasn't been done in women yet.
So you've chosen to give 1 milligram
Mhm.
of the hormone.
Mhm.
What is the baseline of this, of the hormone level, estradiol,
Mhm.
in women, which is your target patient, right?
Mhm.
What's the baseline and why did you choose to have the 1 milligram?
So the baseline is 1 milligram, and then it is increased, I believe, after the first month, and then it is increased to 3 milligrams if necessary in normal treatment for hormone replacement therapy. So I was just following those guidelines.
Considering the other possible effects of estradiol,
Mhm.
of course, as it governs different other metabolic practices and
Mhm.
bodies, do you see any possible side effects of that,
Mhm.
given, the increase as you grow?
Mhm. There would be possible side effects of blood clotting and anemia, and unfortunately, in some cases, cardiovascular health can be affected as well.
And that's why I'm very, very curious, your
Mhm.
baseline, like
Mhm.
what made you decide that it should be the amount?
That's the lowest amount that can be administered, but it can increase. But I don't see that it would be necessary since it's just targeting the receptors in the GI tract, but not entirely sure. Zelensky, it's bioethics. It's just a bioethics that we would follow to make sure that women are safe because they're a vulnerable group. I'm sorry, I can't hear you. So, like I was saying before, it has been done in males before, and this is an FDA-approved drug that is used in hormone replacement therapy already. So we do know the effects of it, and we can just. Can you hear me? Mhm. Um, I'm not entirely sure, just because the previous studies they didn't have an inclusion or exclusion that I've used, but I'm not entirely sure on that one either. Mhm. Mhm.
What the standard is now for women receiving hormone replacement therapy or screening? For those types of things?
For screening, well, this isn't the baseline,
Baseline of your hormone, like, that's what she's trying to.
the 1 milligram.
Yeah, for breast cancer.
I'm not familiar with the breast cancer, no.
I think that's the critical part of that
Mhm.
level, right? That you need to know what the level of hormones your patients are going to get into.
Mhm.
What does the Crohn's disease activity index actually mean?
Okay, so it is a weekly self-assessment, and it can be furthered into physicians taking sonograms and scans to see the levels of inflammation in your stomach, as well as you would report your frequency of using the restroom, vomiting, nausea, acid reflux, activity, and like your bowel, um, hyperactivity in your bowel syndrome.
We have a couple of seats up here if some of you want to come up and grab, if there's seats there as well. So feel free to come up. Okay, so our next presenter is Weston Logue. Weston is graduating with a degree in biology with a concentration in medical sciences and a minor in chemistry. He is from Bradenton, Florida, and has been at SEU for 3.5 years. During his time at SEU, he has made the Dean's List, TA'd for organic chemistry for 1.5 years, served as vice president of PHSO, was a member of Who We Play For, has done chemistry research under the supervision of Dr. Salvatore for 2 years, and took part in our research residency program at Lakeland Regional Health. After graduating, he will be attending Lincoln Memorial University College of Osteopathic Medicine. Awesome, with an anticipated graduation class date of 2028 to pursue his interests in radiology and anesthesiology. Awesome.
Awesome. Well, as she said, my name is Weston Logue, and I will be talking on the feasibility of an opioid use disorder mobile phone intervention to decrease emergency department admissions. So just a little bit of background and stats to current opioid use disorder and management with that. As of from 1999 to 2021, there was over 600,000 people that have died from an opioid use disorder. And in the year of 2022, just in the state of Florida, there was over 45,000 hospitalizations to the emergency department that were non-fatal overdoses, and which is more fatalities per year than motor vehicle accidents. And it's projected that in the year of 2023, EMS will respond to over 2,000 more drug overdoses than the prior year of 2022, which is over 107,000. And the opioid epidemic currently costs the United States $1.5 trillion in 2020, which is an increase from $985 billion in 2019, which is obviously a massive economic concern. Current treatments for opioid use disorder is a usual care, commonly is medical management, which is either buprenorphine and or methadone. This figure just shows, I know these kind of numbers are kind of hard to see up here, but for Florida, it's around 52,000 deaths per year in the year of 2022. And then in California, I wanted to note that it's just over about 900 at 6,000, even though the population difference between California and Florida is 2 times more, with Florida only at about 20 million and California at 40 million, which is alarming for the state of Florida. And this is a graph showing that there's just a continual increase in our opioid overdoses from 2015 all the way to January of 2023. So with that, my specific aims would be to measure the feasibility of a mobile phone opioid management program post-discharge from Lakeland Regional Hospital Harrell Outpatient Services, which is their behavioral wellness, and this is a specific area that they have patients for. And my specific aim too would be to assess patterns of opioid use disorder of the enrolled patients in the intervention group when compared to the control group throughout the program. And my inclusion and exclusion criteria would be 18 plus years of age. This is the inclusion. Diagnosed with opioid use disorder, no other trial enrollment such as rehab centers and other trials that they could be a part of, and as well must have smartphone access. And these exclusions would be non-English or non-Spanish speakers and feelings of psychosis. With my methods, this would include a single-blind randomized control trial. 80 participants would be recruited from the Lakeland Regional Hospital Arrel outpatient services, and they must have a diagnosis currently with opioid use disorder. And this would be done through stratified randomization groups controlling for polysubstance abuse. And the data will be done by a statistician through t-test who is blind. And this is a 2-group intervention and control trial. So the intervention group, it will consist of a brief mobile phone intervention phone call and coaching protocols to be used with self-monitoring questions and automated feedback. The mobile phone coaching protocol will consist of peer coaching sessions and aim to address setting goals, action planning, shaping knowledge, encouraging self-belief, and verbal praise for progress throughout the program. And these are all approved behavioral change strategies and techniques. The self-monitoring questions will be short 5-minute survey questions. This is done through the program on the mobile phone to track the number of days of cravings, quality of life, and the number of opioid uses throughout that specific week. And the messaging will be measured by asking the number of days opioid use, having cravings, feeling down, etc. And the control group consists of participants receiving usual care and no mobile phone intervention. And it will be assessed the same way as the intervention measures. And they will also be emailed a newsletter twice monthly or every other week just to keep them updated and engaged throughout the trial. So my measurements, weeks 1 through 6, there will be 10 questions twice a week and 2 mobile phone calls once a week. And that first week is just going to be a goal setting phone call where they ask, what are your goals with this program? How can we help you achieve those goals? And then that would be monitored throughout the entirety of the program, which would then move to week 6 through 12, which is 10 questions twice per week again, 2 coaching phone calls once a week. And then at the end of week 6 and at the conclusion of week 12, there's 4 questions pertaining to the satisfaction with the intervention grant because this is a feasibility study. And the anticipated results of this would be the number of uses to decrease, their quality of life to increase, and their number of days of cravings would decrease, and with the control staying the same, with the feasibility increasing across all 3 of the uses, quality of life, and cravings throughout the study. These are my references and any questions. Yeah. This was more pertaining to someone diagnosed with an opioid use disorder that has they're addicted to some sort of opioid substance. Yeah, there's current medical treatments that is used. Buprenorphine and methadone are usual care for medical management with that, which would be from a providing physician.
Your exclusion criteria, why did you use that non-English speakers?
Right. Yes, that is true. My thought process behind that would be just the logistics of the study being non-English or non-Spanish, being that would mean more funding would have to go into the app to have different translating for languages and have different funding for different language-speaking coaches, which is already kind of hard to find because I specifically would like peer studies, peer coaches rather, for kind of to have that camaraderie between someone that has gone through this and now has had the training to be a coach throughout something like this. Yeah.
So that's leading to the question
Okay.
to who's the coach?
Mhm.
Are they trained?
Mhm.
And you have 80 participants. How many
Yes.
coaches do you have to cater to the 80?
That's a great question. I was thinking to have per 10 participants to have 1 coach. So it would be 8 coaches overall.
Are these trained?
Yes.
Here, like you said.
They would be peer coaches, and a peer coach is, based from what I've seen in other studies, is someone that has gone through a substance abuse or substance use disorder and has now had training in behavioral coaching and management that can now offer assistance to people that are struggling with the same thing. So I think it provides a little bit more of a benefit to the patient rather than someone fresh out of training that may have not had any personal experience with something like this. Yes.
Okay, so as an introvert, I hate talking on the phone.
Okay.
Is there did you see in the study that it was shown that speaking on the phone was better than texting or emails? Or
but like, would there be something for people who don't necessarily like talking on the phone?
Sure.
It's the chore to do that.
Yeah, that's a great question, actually. So we could modify it to someone that wanted to ask specifically to text, because texting would hopefully be available in this interface app. And most of the communication would be done through texting, where they would write down with their survey questions twice a week. And then hopefully we would have at least one phone call kind of at the beginning of the study to just kind of get an overall feel for how the patient would be with their goals and something throughout the program. Yes.
Are you really developing?
Like right now?
Yeah, like, are you working with LRH?
No, this is hypothesized.
I was going to make a suggestion to use AI instead of a coach.
Yeah.
I think that's going to be
Okay.
a better respondent, and you're not going to trigger your client, because people who have addiction trigger patients with addiction. They just know buzzwords. AI is not going to know those, and you're going to get more.
Right. Plus, maybe that would help with the introverts and costs.
Volume, and
Yeah.
they're going to be awake at 3 in the morning when they're having cravings.
That's true. That is a great point. Thank you.
I think they actually will answer the phone.
I was just gonna say.
That's part of like the whole
That's the thing,
feasibility of the study,
right?
right? It's just to see if this is even would be available. And from past studies, they have had pretty successful trials with these. However, yeah, this would be just a point as to see, and we would follow the University of Duke's protocol for a feasibility study, which is 70% retention rate throughout the study or more.
Yeah, that was gonna be my question. I was gonna say, is it really feasible to expect a drug addict to be honest about
Right.
all of the, you know what I mean, that we all kind of hide our, when we're in sin, we tend to hide the sin, right?
Yeah.
So, like the idea of them being forthcoming, but that is what you're testing, right?
Right.
Whether or not it is feasible. That was my
Last, I'm very curious of your statistics,
Okay.
considering California having free drugs now compared to Florida. Why are we higher? Is it just because that's reported, or you know, like it's very.
That is
I'm
really
puzzled.
interesting.
Is it
Yeah.
like how hospitalized? Like what were the numbers? Were they ER admissions?
Yeah, is it coming from a hospital?
Oh, those
or-
were all just overdose deaths per year per state. So I believe it was like 5,200 in Florida, and then 61 to 6,200.
Yeah, it's not that huge.
Overall,
It's not huge.
overall deaths. Yeah, which is alarming because they have a much higher population. Oh, really? Well, we can check.
Why? Or New York?
Yeah, I thought New York would have been
New
higher.
York
I was
would be
shocked
higher.
that New York.
New York.
Yeah. Or Seattle,
We're close
you know,
to
Washington.
They
So,
maybe
sorry,
they saved
but-
them. Like it's a small, you know what I mean? Maybe in like those areas where it's very condensed, they don't die as quick. Maybe they can get. You know what I mean?
Yeah, yeah, it's not.
It might be
it's not-
something like
it's not
that.
opioid use.
It's deaths, yeah,
Mhm.
that's it. Right, and look, all of us said that, but it says it right at the top. Sorry, Weston.
That's okay. Yes.
The percentage
Percentage of
that's in Florida.
I don't know the exact percentage, just because the number of opioid users to the percentage of death, I think, would be kind of difficult to calculate. But per numbers, it's about 5,300 deaths in one last year. All right. Yes.
So you mentioned that you would be sending a newsletter.
Mhm.
What would that newsletter actually entail?
Yeah.
And would doing that also kind of negate the fact that these folders?
Yeah, so that's a great question. I originally wanted to include that just to have some sort of communication still with the control group, because they're not having the mobile phone intervention, which is the whole basis of the study. But so it would basically just include how the trial is going, what they can expect further along, and just general updates on the trial and how it's going, basically. Yes.
What year are these deaths from?
I believe 2022.
Did you compare this to any other year's deaths? Like the high numbers in Florida were consistently higher? Not an anomaly?
I would believe, I didn't compare. No, I didn't, to answer you, but for my own hypothesis, I would think that they would stay the same. But even still, it is pretty alarming, even if it was just an anomaly.
Lastly, Weston,
Yes.
have you had any feedback on AA? AAs,
Oh,
we have the
right.
meetings.
Mhm.
Have they done something like this where they do actually just phones instead of, and I know they do like meetings, like actual coming together.
Right.
Are they also considering this kind, or have they already seen that that's not effective for AA? We're not going phones, we're really having meetings. Like,
Right.
have you ever
From
had any?
what I've seen, I haven't seen any AA meetings that in a published article that had a description of them doing that of phone calls. It was mainly just the meetings, right? So I think this is kind of like a newer protocol that could be used.
You
Yes.
know, it would be interesting to see if something like, team challenge and stuff from a Christian.
Oh, right.
Aspect.
Yeah.
That whole mentoring idea of,
Mhm.
you know, after time in rehab,
Right.
being discharged with.
And
something
still
like
having
that.
some sort of a communication. That was kind of the whole purpose of it, is to have a
Yeah.
post-care
Yeah.
continuation of
Yeah,
care
that would
after
be very
discharge.
They
Yes.
have better numbers recovery rate.
For the criteria for determining what is considered overdose death the same from state to state?
You're hung up on
I
this.
believe so.
Well, I mean, like, you say, for example, in this state, you say somebody who's, you know, who's got a bunch of opioids in their system, they run their crop road into a telephone pole, you say, oh, yeah, that's we count that as opioid death. But if maybe in California, they don't, because it was actually a car accident that killed them or something like that. I'm wondering, it also could just be, what are we reporting at?
That is true. I'm not sure, but that's a good point. Yeah. Yeah. All right.
Yeah,
Thank you very much.
So I think we're moving now.